Peak Recovery presents Facing Addiction Podcast.
We have a whole generation that we've lost to fentanyl. Just last year, 100,000 people.
You know, even though I didn't want to believe that it was happening or
to respond in healthier ways so that we could give them the best chance that we could.
Hey everybody, welcome to Facing Addiction Podcast. My name's Tyler Tisdale. I'm the founder and CEO of Pinnacle Peak Recovery. On today's episode, I'm sitting down with Dr. Adam McLean, Director of Business Development at the Guest House. Adam, how are you doing?
Good to see you.
Yeah, you too. Thanks for coming on. So if you just want to start off by telling us a little bit about your personal experience and how you got into the field.
You know, I grew up in Flagstaff, Arizona with a colorful adolescence. First, it started with nicotine, and then it progressed all the way to full-blown cocaine addict around the age of like 14. Dropped out of high school and pursued a colorful bunch of criminal activities, dealing drugs. I got a DUI when I was 16. Around the age of 17, I transitioned to injecting opiates. Back then, it was OxyContin, and then like about a week after I turned 18, I went to my pediatrician and I said, "Hey, there's something wrong with my arm," and she didn't really know what to do. You know, there's like Blue's Clues on the wall behind me, and she's like, And so she comes back into the room about 10 minutes later and says, "Hey, we need to get you in the operating room and remove your arm because you've caught something called necrotizing fasciitis, flesh-eating bacteria." And that was like the moment that my parents became aware that their baby boy wasn't just like smoking really strong pot, you know, like that was when they're like, "Oh, our son is a drug addict." And I got to keep the arm. I have these pretty intense scars all across my upper body, but you know, and it went from bad to worse. Then I went to treatment, but I wasn't really invested in going to treatment. And back then we weren't treating opioid addiction for young adults the way that we are today. This was back in 2004. And one thing led to another, and I started working for the Mexican cartel, transporting illegal immigrants. I didn't know it at the time. All I knew is there was just a guy named Frank who would pay me an envelope full of cash and an envelope full of heroin to drive an RV back and forth to and from Mexico like 3 times a week.
Did you know there were people in the back?
Yes, yeah. So I would start at 51st and Indian School, and then drive down to Mexico through Ajo Pass, park at the border, you know, get loaded, and then when I woke up the next morning, there would be like 8 new strangers / best friends in the RV, and I'd just put on a sombrero and drive back, and like it was never a thing.
A sombrero?
Yeah, you know, like, I'm coming from Rocky Point.
Oh yeah, I got you.
Eventually they found me to be unreliable. And so by this time I had burnt like every bridge, right? My parents them bailing me out wasn't effective anymore. I didn't have any friends that were like really invested in being around me. And so I started burglarizing pharmacies. And on the last, there was only so many pharmacies in Flagstaff, Arizona. And the last one, I was, you know, on every substance found in a pharmacy, right? And so I'm like hallucinating. And I thought if I wore this butcher coat that they would think that I was a pharmacist. And I'm like delusional, hearing voices, crawling around on this pharmacy wearing a butcher coat. And it's the last pharmacy in Flagstaff. And so I'm taking everything. And I'm walking out of the back of this grocery store, and I'm pushing this cart with just pill bottles, and it's like slipping out of the edges. And these people stop me, and they're like, "What are you doing?" I was like, "I don't know." And they ended up the detectives have been waiting for this moment for like a couple months, and so I spent the next year of my life incarcerated, waiting for a plea agreement. And because all this happened in a very short period of time, they had to wait until all of the charges had been brought against me. And then I was really fortunate to be enrolled into a DUI drug court up in Coconino County, which is an alternative sentencing protocol, which saved my life.
And that was after the year?
Yeah, because I just had to wait for all the charges to catch up.
I did that too, unsentenced.
Yeah, it's hard. It's hard. It's a lot of waiting. You know, you play a lot of spades and cards and do a lot of laundry. And through that program, I struggled quite a bit. And you know, they would drug test me 3 times a week on Monday, Wednesday, Friday. And I would always try to play this game of like go test on Friday morning and then get loaded Friday afternoon and then try to clean out by Monday. That never worked.
No. Yeah.
But come like Monday morning, I was still getting loaded, and I was not able to stop on my own accord. So eventually in that program, towards the end, this was back in 2005, a pharmaceutical, Suboxone, had just come on the market. Back in 2002, it came on the market for use for treating substance use disorder. And I actually had been sober for a while, but they introduced it regardless. And so I'd do this like dance where I'd like take Suboxone and then do heroin, and take Suboxone and do heroin. And finally on November 28th, 2006, my probation officer came to me and said, "Hey, your drug test came back positive again. What do you want? Like, what's going on?" And every time previous to that, I'd always been dishonest. I'd always been like, "Oh, that's not mine," or "There's a mix up," or, like I create these like delusions of what happened. And I was, instead of sending me to prison on my 7th sanction, they gave me the opportunity to go to treatment, but for real this time. And when I went to treatment this time, I still was doing like the, talking the talk, but not walking the walk. Like, oh, I'm going to go to meetings and I'm going to do everything necessary. Just like, stop with this. Like, if everybody would just let me do what I need to do and let me move on, everything would be fine. But there was another guy, and his name's Tyler. There was another young opiate addict in that treatment program. And I remember when he graduated the program, we were doing like a coin out ceremony, and his mom was there, and she was just talking about how happy she was. She was so proud that her baby boy was like going to be okay, that she wasn't going to have to worry about that phone call anymore. And I knew that he was talking the talk, that he had been like cheeking his Valium and stuff like that, or Klonopin. But like still, I could really resonate with watching his mom, because I've always kind of been a mama's boy, because my mom was always the one to come in and like try to alleviate some of the burden of my consequences for my behavior. 2 days later, the therapist came in with tears in their eyes and told us that he thought that he could go back out one more time, and that he had overdosed and died. And that's when it clicked. I was like, oh, I'm going to die from this. And all of those sleepless nights that my mother had suffered, and both my parents, were going to be for nothing. And so I started paying attention to what the counselors at the treatment center said. So I got highly involved with the 12-step community and engaging in everything that they suggested, going to therapy, doing intensive outpatient programming. And that's where, that was a fork in the road. And that's where initially I got invested into my own recovery.
Wow, that's an incredible story. So leading from that, how did you get into the behavioral health field?
Yeah, so when I got out of treatment, part of the requirement for my probation through the DUI drug court was to get a job. And I was really scared that I wasn't going to be employable, because, I had all these I had 34 felonies. Like
34?
Yeah, it was bad.
Dang.
And I was really fortunate, and I got a job at one of the gyms up there in this place called the Flagstaff Athletic Club. And they gave me an opportunity to work in the membership sales department, and it was great. Like, because, we pay a lot of money for our street smarts when we're in our active addiction. So it was nice to be able to apply that into my emerging adult life. Yeah. And so I was, and also working at a gym was really cool, because like I learned about like exercise and nutrition, and like I am under the belief that we can't get rid of a habit, we can just replace it, right? And there's like some really fascinating research around that. But specifically what happened when I was working at the gym is there was a guy that I knew from the 12-step meetings that I was attending, and I was talking to him while I was signing him up for a membership. And I was like, I really want to go to nursing school. But my working at this gym isn't going to be conducive to that. He's like, oh, well, why don't you come work at this treatment center, the one that I had actually gone through, and you can work nights and you can do nursing school during the day. And so I was like, that sounds pretty cool. So I went and worked as a behavioral health technician, and it was like full circle, man. It was like, at once as a client and now working as a tech and doing charts and running groups and learning the ways of the business. And I fell in love. Like, it felt like life had found me. And it was a boot camp learning experience. And additionally, what was really neat about that was the people that were around me some of them were in similar circumstances, like they had gone through treatment or were in recovery and were enthusiastic about that or passionate about that. But there was also another group of people that were in their college courses trying to get experience. And so there was, just like working at the gym where like I found like a new enthusiasm for exercise and nutrition. Now I'm exposed to another group of people that made it so that I was enthusiastic about education. And, you know, they would say things, and this is, you know, 2006, 2007, they would say things like, well, you know, there's a huge correlation between trauma and addiction. I'd be like, what's trauma?
What's correlation?
Right, exactly. Right. And this is like, dude, I was a high school dropout at the age of 14. Everything I learned was really as a result of just through my addiction. And so I became interested, and eventually it's like that saying, water seeks its own level. So I enrolled in some courses, and I grossly overpaid for my bachelor's degree. And one thing led to another, and I left that job and helped create a treatment center up in Flagstaff, Arizona, that had it was a wilderness component and like a structured sober living environment. And one thing with that experience that I noticed is that there was a lot of people that had come from this there used to be this, what is it called? Synanon. There used to be something called Synanon, which is a very shame-based model of treatment back in the 60s. You know, is very, it's called the therapeutic community environment model. Now that's evolved to a much more clinical model, but that kind of bled its way into the treatment in the early 2000s. And I was watching these like shame-based model treatments be exhibited of like trying to shame people into like change behavior. And something clicked with that where it just kind of felt really incongruent with like me and not wanting to be a part of something like along those lines. And so that's when I made the decision to start pursuing clinical degrees. So after I got my bachelor's, I went and got a master's in clinical psych. And then I was just, you know, on a roll. So I figured, why stop here?
So then you got your doctorate?
Yeah.
Let's circle back about what you said about replacing a habit with another habit or an addiction with a habit. What type of research have you seen on that?
It's the way that the brain forms neuroplasticity, right? Is the way that we engage in behaviors. Is that there's like this old kind of saying where it takes like 2 weeks to establish the habit. And why we have that saying is because of a process referred to as neuroplasticity. We used to think that the brain was basically just like a bunch of brain cells, and that when you used them, you burned them, and that they were all gone. That's why we used to have these commercials of like, this is your brain on drugs, and they'd show the cooking eggs. Yeah. And what we now know is that the brain is very different. It's more plastic. It's always learning and forming new grooves, which is what's referred to as neuroplasticity. But, you know, like we live in Phoenix, Arizona. Imagine that every day of your life, in order to get from your home to your work, you have to take the 101. And then all of a sudden, during one of the seasons, we find out that the 101 is now under construction and we can't take that way anymore. The brain, similarly, from that metaphor, will find a new way to get to our destination, but it still has to get to the destination. And so that leads us into a conversation around dopamine, serotonin, opioid receptors. Like one way or another, we're going to still get to the end result, but how we get there is going to change. And that's where I think that it's really important to talk about how a lot of people, when they view addiction as the problem. And I think that is a little backwards, because addiction is not the problem. The addiction is the solution. It's a strategy that most people establish because of what's going on with them, in which some people might call trauma, other people might call attachment disorder, whatever. But it's a solution. It's a strategy. And when we know, and like we've known this for a long time, right? Like one of the co-founders of Alcoholics Anonymous, Bill Wilson, he talks about having shell shock from World War I. And then they write about it in the book of Alcoholics Anonymous. Alcohol was but a symptom. Bottles were but symbols. And Bill had his own experience in 1957 where he sought out medication-assisted therapy for his depression, which depression for him, I think, is synonymous with complex PTSD.
Yeah, he was working with, what was the doctor's name? You remember?
I don't remember. I'd have to look it up. They have a good website with all the facts on that.
It's super fascinating, and just kind of moving in that direction.
Yeah, we've turned a lot of corners. I mean, between psilocybin, ketamine treatment, even buprenorphine, Suboxone. I mean, things like psilocybin. In my doctorate, I remember there were other students that were that they would come back from a weekend and they would refer to taking research drugs. Suboxone was nothing more than a research drug. In the 1960s, buprenorphine, they were trying to find something that was stronger than morphine. And so they created this opioid, buprenorphine, which is like 3,000 times stronger. Before I digress, the drugs like taking ketamine, psilocybin, microdosing LSD is no different. I think where there's a differentiator is when we start exploring, okay, is this in conjunction to clinical therapy or is this for recreational purposes? And I think that's what differentiates whether or not it's therapeutic.
Okay. So let's dive more into ketamine, LSD, psilocybin. What type of research have you done on that? What have you learned?
So, the research is still developing and it's changing pretty significantly. And so I can't speak to it too intelligently. What the research that I'm aware of at this point in time is that when we have an individual that suffers from major depressive disorders or persistent depression, and they are medication resistant, and that it's a very long conversation about how depression medication works. But if somebody's taking an SSRI or SRNI and they're not experiencing any relief from that, then it is appropriate to explore or have a conversation about taking, ketamine treatments or psilocybin or microdosing LSD. Now, a lot of that, and the research is very clear, that is not the case for people that have a history of substance use disorder. So just so that the differentiation is there, if somebody has a pretty significant history of suicidality or substance use disorder, they should not be a candidate for microdosing.
Really?
Yeah, but the same is true for benzodiazepines, right? Like people that take benzodiazepines for anxiety or panic disorder, the prescribing details of that are very clear. If somebody has a history of suicidality, they should not take those.
Okay.
But, a lot of people experience a lot of relief from that. So I just ultimately the sentiment that I have around it is that it's not a cookie cutter, one size fits all. We really need to take a look at the person as a whole and make an informed decision.
Okay. What type of results have you seen just based on the data? I'm sure through school and...
Yeah, they don't teach this stuff in graduate school. Usually you have to go do your own research.
Okay.
A lot of... it depends on the person. It depends on who's providing the services. So a good example of this would be ECT, right? Electroconvulsive therapy. Everybody's seen that movie, One Flew Over the Cuckoo's Nest. It used to be that that was very frowned upon to do that. But as they develop the science and get more concise in the results, that the benefits are there as far as percentages of people that experience a decrease in depressive symptoms, I don't know. Ironically, going back to what I had talked about earlier, Harvard actually, which you mentioned that you're going to go do a course in, which is really cool. Harvard did a really fascinating study where they took 3 groups. One group did antidepressant medication, an SSRI. One group did exercise, and then another group did both. All 3 groups had a decrease in depressive symptoms. But after a 6-month follow-up study, only the individuals that continued to exercise were the people that had a decrease that did not have a relapse in depression.
Really?
Yeah. So, I mean but as far as the effectiveness of ketamine, I have personally seen it work in others in a profound way. And I have people in my life that I know from the recovery community that they had persistent depression for a long time, and they've done ketamine treatments, and they're experiencing profound results. I remember there's one gentleman where he picked up the phone, and I knew just the way he said hello that I was talking to a very new person. And he had been suffering from suicidality for a very long time. So I don't think that we're there yet where we can say definitively 60% of the people are going to have a decrease in symptomology. But from an anecdotal, personal experience, I've seen it be pretty effective for people.
I've heard people tell me that in 10 years, the recovery industry will look like treatment centers offering microdosing, psilocybin, LSD, ketamine. What do you think? Based on what you just said about the caution of substance use disorder.
A good parallel to that, or some setting the stage, is we have research around whether or not buprenorphine is effective for people with opioid use disorder.
Yeah.
there are going to be people that are very reluctant or resistant to implementing that into a residential programming, but it depends on what they're being treated for. You know, there's a difference between a 19-year-old that is only been using for the past 6 months, and we haven't like tried other therapeutic modalities, and the 42-year-old that has had multiple suicide attempts, has been in recovery from substance use disorder for 10 years, but is still depressed. I think that there's just a difference there. And so we have to take a look at the person, not necessarily just rolling the dice, hoping to God that like this works. But the risk is pretty minimal, especially with like ketamine and microdosing. As long as there's somebody with I would suggest a licensed master's level clinician or above that can provide clinical services in conjunction with the treatment, the risk is pretty minimal.
So the 19 and the 42-year-old, is there other examples of how we should approach these two cases?
Yeah, and so that goes back to what we were talking about before with buprenorphine or Suboxone, Subutex, whatever you want to call it. And buprenorphine is a fascinating drug. When in the 60s, they were trying to synthesize an opioid that was stronger than morphine for pain, and they were successful with in around 1967 and then it finally came on market around 1982, but it was for pain management, specifically for a high acuity of pain. And that's when we were around that time is when we were introduced to a medication referred to as Subutex. But Subutex and any other buprenorphine products had a very high abuse potential. And here in the States, buprenorphine is a Schedule III narcotic, which has therapeutic value and some abuse potential, but not nearly as bad as something like, oxycodone or Ritalin. And so in the UK really was a lot, they started adopting this practice a lot sooner, but they started developing a combination drug, which took buprenorphine, which is a very potent opioid. It's 3,000 times more potent than morphine. But the fascinating thing about buprenorphine is that there's a ceiling effect. So if we could imagine like a line graph, methadone or heroin or any other, most opioids, you take more of the substance and you're going to experience more euphoria. With buprenorphine, you're going to shoot up way faster than you are with any other opioid, but you're going to level off and you're going to stay at that leveling off process. But still there's abuse potential. And so in 2002, we started it got approved through the FDA to use a combination of buprenorphine and naloxone, or what a lot of people are familiar with, like naltrexone. Naloxone is an opioid antagonist, meaning it completely blocks off the receptor sites from anything getting in, which is another fascinating chemical composition because naltrexone is essentially like the most potent opioid known to humankind.
Really?
It is, except for if we just have to flip the chemical makeup, is we'd have to take a couple pluses and make them minuses because it's the way that it binds to the receptor sites. And so in 2002, we started rolling out the Suboxone, which they had a patent on it for up until, that was about 2018. So I think they had like a 16-year patent. It wasn't widely prescribed right away because we didn't have the opioid crisis that we do today. Like the opioid crisis was developing in like your and my heyday, right? Like that like 2004 to 2009 period. And then it just skyrocketed. Then all of a sudden now we have, 190 individuals dying from an overdose a day. Which climbed above any other premature death, including our car accidents or heart disease, for people under the age of 28. And so when you asked about like, okay, what's the difference between the 19-year-old versus the 42-year-old, I think it's about responsible prescribing and what I've heard some really fascinating people call like prescribing with purpose, which is a 19-year-old. I don't know if they've been using opiates, if it's an appropriate measure to put them on what's referred to as a partial agonist, which is what Suboxone is. I don't know if it's responsible to put them on that for the next 5 to 10 years. However, somebody that is like 45 years old, has a family, has tried multiple different treatment episodes, and cannot stop using illicit substances, maintenance might be something to really consider. But I think that should be our last form of defense. I think that if I had a magic wand and I could say exactly what I think would be most effective, especially with what we're facing right now between Because fentanyl. It's the fentanyl piece that scares me the most, because there is a very, very low dose of naloxone in buprenorphine, which it's hard, but somebody can circumvent that with fentanyl or carfentanil and then some of the other synthetics that are coming out. In that instance, what's the most appropriate course of action to take is to first bring the person in and use a substance like Suboxone or another buprenorphine product like Subsolve, and there's quite a few of them. Use one of those to make it withdrawal management, and then from there, then transition them over to something like naltrexone or Vivitrol, because Vivitrol, when we take a step back and really take a look at it, Vivitrol is the closest thing that we have to a vaccine to the amount of kids that are dying from opioid overdose. Do I think that everybody should get like a naltrexone implanted behind their liver for the next 5 years? I don't know. It feels a little big brotherish, but there's a lot of people that are dying, and it's something that we need to take into consideration. If we are looking at substance use disorders through the same pathological lens that we were to any other disease that's similar in etiology, which substance use disorder looks very similar to type 2 diabetes, asthma, hypertension, most forms of cancer. How we treat those diseases here in the United States, there's a very successful treatment plan. It starts with essentially the person getting an ambulance, then going to the emergency room and getting stabilized. Then once they're stable, they go up to the 13th floor and learn about lifestyle changes and medication management. Then really for the rest of their life, they're engaged in some sort of monitoring case management process. So somebody that all of a sudden is type 2 diabetes because of genetics and nutrition and multitude of other factors, that person is likely going to be on some form of medication for a very long time. Same with hypertension, same with asthma, same with most forms of cancer. But ultimately what ends up happening is that if somebody has type 2 diabetes, they're on a spectrum. Some of them will need to take a shot of insulin twice a day, every day. Some of them will be able to manage with a prescription of metformin that they take in the morning. And some individuals will exercise and engage in healthy eating habits and not have to take medication. The point I'm trying to make is that the person with type 2 diabetes has a similar parallel to the individual with an opioid use disorder. It's not a one size fits all. We need to treat the person on their symptoms, what's going on with their labs, what's going on with their brain, what's going on in their life. And in that instance, we can make an informed decision on what's best for that person, not what's best for what we think is best for them without any details of what's going on with them.
For sure. And it's not as black and white as 19 and 42. It's pretty complex in my experience and opinion. Like, here's an example, and would love to get your take on this. Let's say the 19-year-old is completely unwilling to do an abstinence-based path. He's using fentanyl, and the only thing he's open to is Suboxone.
I may need to acquiesce on my personal opinion about things so that we can keep that kid alive long enough so that maybe, just maybe, they'll have a shot at an abstinence-based recovery experience. But with the way that people are dying at this rate, that is not necessarily always the case.
What do you mean?
So, like, I guess what I'm saying is I need to double down on my opinion on that. Even though I currently live in an abstinence-based recovery, that may not be everybody's journey.
Oh yeah, I agree. I'm abstinence-based as well, but my brother is on medication-assisted treatment. He is 41, has 6 years sober, living an amazing life. He's in the union, like, very successful.
Yeah.
Like, so that opened up my mind, like, different paths for different people. Like, as long as you're happy and your life's manageable, and that's all that matters to me.
Which is really cool to hear you say that, and congratulations to your brother. And also there's this really cool, and I mentioned this before, Suboxone and buprenorphine, all the buprenorphine medications, they have a ceiling effect. So, and they're a Schedule 3 narcotic, which means that the abuse potential is pretty low. Because the euphoria is not very high. And so there's a lot of people that have really strong opinions about whether or not buprenorphine is actually in recovery and if that person's high. And we are more likely to experience some type of chemical alteration in the brain with a combination of nicotine and caffeine combined than we are on somebody that is going to be taking buprenorphine. There's so many myths around the prescribing of buprenorphine because really the therapeutic dose of buprenorphine caps out at 16 milligrams. Mm-hmm. Some doctors, and this is more like 10, 15 years ago, there's still some doctors that are giving out 8 milligrams 3 times a day. If you're inducing and you're trying to push past that initial fentanyl, great. But besides that, like there is no therapeutic value. That's not right. There is very limited therapeutic value of more than 16 milligrams. Somebody can go from 16 milligrams to 4 milligrams without issue. They're not going to experience any discomfort. It's those last 2 milligrams. That 2 milligram ledge is the hardest. Yeah.
What dictates getting someone off Suboxone opposed to just using it for the rest of your life? Because you mentioned if you have diabetes and some of these other diseases that you're on meds for the rest of your life.
Yeah, unless you implement, so exactly to that point, right? If you have hypertension, to type 2 diabetes, you're going to be on medication for the rest of your life unless you implement lifestyle changes. And the same is true for substance use disorder in a lot of instances, especially if we're talking about buprenorphine. And and that was one of the fallacies and the mistakes that we implemented when we put all these people on methadone when they got back, is we had a lot of war vets coming back from Vietnam, and about 10% of them remained addicted, and we put them on methadone. And the problem with methadone is that there was no exit strategy, and buprenorphine, we have a better opportunity for an exit strategy with the lower doses. And so there are other medications besides Suboxone that's coming on that are, because Suboxone, the lowest you can really get is the 2 milligrams, and then you can like cut those into like quarters and fourths. But there are other medications so that we can titrate. So as far as getting off of something like that, it's no different. Like if we're going to, make Suboxone this pariah, the same is true for SSRIs. Like, I don't know if anybody has ever had a loved one that's tried to titrate off of Wellbutrin, but it's not always a pretty scene. Like, there's discomfort. Talk to somebody that is trying to quit all sugar cold turkey. The body is going to go through a withdrawal or detox period. What is fascinating about buprenorphine products or medication-assisted therapy in that regard is that we can continue medication-assisted therapy with substances that have no abuse potential, right? We can give them something for sleep. We can give them something for their muscle aches. We can give them something for the digestive issues and help them through that 7 to 10 day window. But usually not usually, like it would be advised that would be at the benefit of somebody, a medical prescribing professional.
Yeah, absolutely. So we touched on what it may look like for the 19-year-old who's unwilling. And that in my mind is harm reduction, is kind of meeting people where they're at and trying to keep them alive until they are willing, and get them on an abstinence-based path and really have the opportunities that we've been afforded with. Because if you're dead, you have zero chance. So this is where it gets a little murky, I think, for everyone, is where do boundaries and harm reduction coexist, or where do they meet? Because you have this 19-year-old that's living at home or wherever it might be. People listening or watching may have a loved one who's struggling with addiction. So we want to keep them alive, but we still have to have our own boundaries and protect ourselves too. So have you ever thought about that, on where those two may coexist?
Have you ever seen that show, Intervention on A&E?
Yeah.
Yeah. So it used to be that, like if we wanted to intervene on someone, it was these hardline boundaries, and it's like, nope, you either go to rehab today or you're not invited to Christmas. And some clinicians came out with like some really fascinating research around like more of an invitational approach. And I know I'm digressing a little bit, but I'll get to the point, which is it's an invitational approach. It's a collaboration, family systems, systemic approach. And there is some negotiation there. But it has to be a conversation, right? And so it's like, hey, if you're going to continue to live in my home, then these are the boundaries that are important for me. And then if you can't meet those, then this is the way that this dynamic is going to change. And you can also double down on that, especially around with harm reduction. It's like, okay, what I hear you saying is that you are not able to get off of heroin and fentanyl right now, but you're willing to take buprenorphine for a period of time. But can we put a bookend on that? Can we have a conversation about an appropriate length of time where we reevaluate the situation? In addition to, can we also agree that if you continue to use while on buprenorphine or another Schedule 3 medication, that we're both now in agreement that this did not work the way that you proposed it would, and we need to explore other options like residential treatment or exploring like a more definitive medication like we had talked about earlier with like naltrexone or Vivitrol. They even have the naltrexone implants now.
You mentioned asthma, hypertension, and diabetes. I've seen some interesting research that shows that those three have a very similar relapse rate to addiction. What's your thoughts on that?
Type 2 diabetes is the easiest because it parallels substance use disorder like the best. And so if somebody, say, overcomes type 2 diabetes, like they start with insulin, then they go to metformin, they start exercising, they start eating healthy. Now all of a sudden their pancreas is producing the correct amount of insulin, and they really no longer have the symptomology of somebody with type 2 diabetes. The same could be very true with somebody with substance use disorder. But there's this key element of lifestyle changes, right? Like that's really important. And we see that with people with addiction and more, what would be better said, people in recovery. They start changing their lives. They go back to school or they get a job and they start families and, they get married and go on honeymoons and, they get car insurance. Like it's crazy.
Yeah.
But there can also be a relapse in behavior. And that was my story. And that was like what happened for me is that a lot of my addiction and my substance use rooted from something much deeper than just like deviant behavior, right? Like there's this old that person is just like a victim of their choices. I don't necessarily agree with that. I think that a lot of people had experienced some pretty significant wounds and they established strategies around those wounds. But as we talked about before with neuroplasticity, like that doesn't just go away. Like the brain remembers. It's a much longer conversation, but dopamine, the feel-good chemical in the brain, if somebody does methamphetamine, that produces like a numerical equivalent of about 1,300. Now, likewise, if that person eats chocolate, like really delicious cheesecake chocolate, it's going to be about 180. If they have very passionate sex, it's going to be around 200 and 220. So essentially what I'm trying to say is that the brain will now associate methamphetamine to survival 6 times more than it would with procreation. It's hard for the brain to let go of that, even with all of the neuroplasticity and what we do through lifestyle changes. And so what happened for me is I had an experience where I ironically blew out my knee in a yoga class, and I blew out my LCL. I heard a pop, and I started taking a synthetic medication that I did not. The abuse potential was very limited there, but it scratched an itch that hadn't been scratched in a really long time. And I hadn't protected or ensured my recovery the way that I should have been for a long time. And that led to it progressing, just like any other of these diseases that you mentioned before, type 2 diabetes, asthma, hypertension, they are progressive in nature, and so is addiction. And so I wasn't insulated, I wasn't protected, I wasn't taking an active role in my recovery. And so I was vulnerable. Due to my own choices and behaviors, I was vulnerable. And that led to me needing to do some more work. Now, I was in an interesting position, and I have always had that feeling of being uncomfortable in my own skin, lonely in a crowd, an outsider looking in. It just, most days I wonder like why I missed that one day in kindergarten where they taught all the other kids how to participate in the human race. And I think that all resorts back to trauma. And so I went to a program out in Florida called The Guest House, which was started by Judy Crane and John West. And Judy Crane was one of the first people in the industry to say, we're looking at addiction wrong. We're looking at the behaviors that they're engaging in right now and not looking at why they're engaging in them. Because trauma is not what happened to us. Trauma is how we responded and how we feel about what happened to us. And so they created this program called The Guest House, and I was afforded the opportunity to come work with them some time ago, which it's not a drug and alcohol rehab. It's a trauma program that addresses maladaptive coping mechanisms like substance use or disordered eating or whatever it may be. Not everybody that comes to us has an addiction. 100% of the people that come to the guest house, they have trauma or what they might call depression and anxiety. And then whatever medicating behaviors come with that. But we can have compulsions and addictions to a lot of things besides just substances. You know, there's workaholism, codependency, relationships, social media. There's a lot. All of those behaviors produce dopamine in the brain. And so we can get addicted to that behavior just like we can anything else that's addictive. And anyway, so so that's what we do at the guest house. We treat trauma.
So what's the process look like? Is it a 30-day program?
It's a 90-day program. The minimum length of stay that somebody comes to us is 30.
Okay.
In order for us to really feel like we gave them everything that we wanted to provide and more, we would like them to be with us for 90 days. But, you know, you get it, you know, father with a job, like it's hard to get away for that long sometimes. And so it is, it's advised to come for 90 days minimum, but some people literally cannot come for more than 30 because of their jobs or family obligations.
And so what does treatment day-to-day look like there? Is it group therapy, experiential therapy, individual?
Yes, and yes. It's all the above. And so trauma doesn't exist in the prefrontal cortex. We have this part in our brain that is responsible for logic and judgment. It's what differentiates humans from most other mammals and all mammals. But that's not where trauma rests. Trauma rests further back in the brain, in the midbrain. And that's where we have processing for memory. And so when you and I can have a conversation about maybe something that happened to us while we were engaging in our addictive behaviors, and we can have the conversation, but then if a clinician or a psychologist or someone a counselor says, well, how did that make you feel? We would have no idea what they're talking about because we live neck up, which is all cerebral, right? That's very logical. So as soon as people start asking for us to get into our feelings, at least for a guy like me, it's really hard to do so. So there are therapeutic modalities that we can implement that get to circumvent that prefrontal cortex. Things like EMDR, somatic experiencing, accelerated resolution therapy, neuroaffective relational model, psychodrama, art therapy, equine, cinema therapy. I mean, anything that gets people out of their prefrontal cortex is going to give us a side door into the psyche. And so that's why didactic therapy of just like a narrative isn't that effective with trauma. It's good at getting the story out there, and telling our story is a really big part of recovery. But as far as reprocessing disturbing memories, it takes a more clinical sophistication that like that you would receive in a residential program.
That sounds like an awesome program, man. How can we get in touch with you?
I think the most effective way would probably just start with going to the website and calling the 800 number, which is theguesthouseocala.com.
Okay. And
then people can look me up on there, and there's a contact form, and just look for Adam McLean on theguesthouseocala.com.
Are you on LinkedIn?
LinkedIn, all social media platforms.
All right, cool. Yeah, so if you want to get in touch with Adam, check him out on LinkedIn. Appreciate you guys watching the show, and thanks for coming on, man.